So today we're going to talk about practical approach to delirium. I do want you all to understand some of what delirium is, what's caused, a little bit about what causes it, and then approach to it. It's hopefully somewhat practical, although there certainly is theoretical. I will warn you that this is really aimed at a physician level, and so it is, and probably would teach a lot. And in fact, I know that when I give this to physicians that they've told me that they've learned a lot. So I hope that doesn't intimidate you. I think of the nurses here as being able to know more in many cases about this type of medicine than most physicians. So I have confidence in you all, and I hope everyone has plenty to get out of it. Because I think so. I do not have any financial disclosures, unfortunately. So hypothetical case, we get a phone call from a daughter of someone with stage 4 lung cancer. Can't handle her. She's getting more confused. She's shouting out, hitting at me, cursing at me, barely eating, drinking, won't stay in bed. She's fallen. Been up all night, 2 nights. No idea what to do. Does this sound at all familiar? Yeah. What is this? Obviously. All right, well, there's your easy one. So today we're going to discuss a little bit about what it is, the importance of watching for it and how to do that, how to evaluate it, starting with history and physical, labs, a variety of treatment strategies, including non-pharmacological strategies, how to reverse reversible causes, simplifying medications, and then issues of hydration, opiate rotation, Haldol, and sedation as options. So first question is, what is delirium? Is anyone brave enough to try a definition of delirium? Or give me some idea about what it is? No one's brave.
It's an altered mental state.
Very good. All right. That's a good place to start. An altered mental status. If I fall asleep during the talk, that is an altered mental state. That's not necessarily delirium, although that's argued. But that is excellent, and that's a great place to start. We'll use a DSM diagnosis for the social workers here. Oh, wait, no, I'm sorry. Actually, let me start with some things that it's not equivalent to, although it can be confused with. It hasn't happened as much here, but I used to get calls all the time. This person is restless. What do you want us to do for it? What can we give it? Well, restlessness could be any number of things. Probably shouldn't have had it all written up there. I could kind of pull this out of you all, but people are sometimes restless because they're hurting. They may be cramping in particular. They may be tossing and turning. If they're constipated, urinary retention. There may be emotional or spiritual distress. And I've had one patient just was always kind of moving around. The family said, yeah, but she's been this way her entire life. She never stayed still for 5 seconds. Akathisia can cause a restlessness where you just don't want to stay still from haloperidol or other antipsychotics. So restlessness is not equivalent to delirium. Yes, delirium can cause restlessness, but restlessness is not equal to delirium. How about, is it the same as confusion? Well, confusion certainly could be delirium. They are confused, but so are patients who are demented. Sometimes people give very inappropriate answers if they just can't hear you, and they don't want to admit it. Depression. People with depression, there's overlap with depression and delirium in the elderly. There's also can be confusion. Someone who's depressed may just not have any incentive to answer you, may just not be able to get up the energy to even think of how to answer you, let alone how to do it, how to actually answer you if it's severe enough depression. How about agitation? Well, it may be delirium, certainly that can cause it, but there is a state of agitation that can come with dementia. And this is one of the reasons that we have to be a little cautious about a chronically difficult to manage patient in a setting where we're not prepared to handle that. Someone comes in, if they're confused and someone comes in to change, take off their clothes, they have no idea where they are, who this person is, they're going to be fighting out, kicking. That doesn't mean they're delirious and that you need to therefore give them Haldol. That means that you need to take a different approach and using behavioral strategies, because that is not an alteration in their mental status. That unfortunately is their mental status. Some people have real anger issues and just no control, and so that can come out, particularly if there is some element of dementia. Pain can cause some element of agitation and, of course, emotional distress. There's, so not necessarily either of these things. So here is our DSM definition. There's well, I guess 4 parts really to it. The first one has to do with disturbance in consciousness, and that includes changes in attention. And so these are people who may be sound asleep one moment, wide awake and agitated the next moment. Half an hour later, they're staring at the ceiling and just barely responding, and then they're more or less fairly clear and able to have a reasonable conversation for a while. And so their level of consciousness is varied, and their attention is often poor. So you ask someone a question, they might get it. You get one question, but then you'll ask them a question, and then you'll realize they're just kind of staring, and they started off thinking about it, but within a few seconds they completely lost their train of thought. And you have to ask them 2 or 3 times before they may actually be able to pay attention long enough to do that. They may just be staring. So there's poor attention span. Then, so there has to be consciousness changes or attention issues. There has to be some kind of cognition, thinking, or perceptual disturbances. So these people are often kind of confused. They may not really remember where they are. They may have some problems with correctly speaking, and they may be hallucinating. It may be active hallucinations where they're seeing things that aren't that aren't there. I was told that may not. Well, I guess if you're back there, that should be okay. I don't know. I don't. You might be a little bit on the camera. So verbal hallucinations are less common, but certainly can be. There's also delusions. They get things stuck in their head. Another part of the definition is it develops rapidly. This is not something that happens over years or months, generally even weeks. This is over days or hours that it's changed recently. So that's as opposed to a dementia picture, and it fluctuates. So that again, they're changing. They're not the same all the time. It fluctuates from one moment to the next. How bad it is, how alert they are, all that. The final one is very vague. Should I ask Meg to move just because, no? Okay, all right.
I'll see around.
I just see you moving.
It's you. You're the one we can't see.
So, evidence of cause by a general medical condition. This is a very vague one, very general, and basically all of our patients have evidence of cause by a general medical condition. So this is pretty much assumed, this is pretty much in there to differentiate it from a psychotic break. Or something like that. Now, this is frequently missed. There were 2 studies that were done that I'm specifically referring to. One was of delirious patients in an ER setting. Another one was elderly patients coming in with depression in clinics. And they noted that when they evaluate them, of the people that they ended up determining had delirium, 93 to 96% of these people were missed and was not identified as a diagnosis when they came in. It doesn't mean that 93% of these patients had it, but of the people who did, they were almost all missed. Why is that? Well, you can miss it really easily, especially if it's the hypoactive type. Obviously, if they're throwing things, if they're agitated, they're screaming, they're fighting, they're restless, you're not going to miss that. That's pretty obvious to everyone. And they're probably going to be coming in for different reasons. But if they're just kind of staring and not really with it, not really paying attention, and not really very clear, it's missed a lot. So this hypoactive delirium is easy to miss. So who cares, right? These people are staring out into space. You talk to them, and they might answer you. They may well tell you they're very comfortable and nothing's wrong. Just kind of leave them alone. And if they can answer you, but half the time they'll be spacing out. Really probably aren't eating or drinking because it just isn't on their radar screen. They're just, they might get a bite halfway to their mouth, but just not really be able to pay attention to it. So they generally don't really eat or drink. So why should we even care? Question for you guys. Why is there any reason we should even care about hypoactive delirium? There's no obvious distress.
Because they might feel better if they weren't. The family might want to interact with them.
Okay, so family might want to interact with them. Good. Anyone else?
Just help the patient's overall well-being to treat it if they could come back to a better state of mind.
So if they're more clear, many people would value that. In fact, and this really struck me when I was talking to people earlier with palliative care and asking them what was important to them. And one of the answers that kept coming up over and over and over again was mentally clear, that they're with it, that they're able to converse with family and understand things. Comparing studies show that it's very high percentage, value that very highly, and it is also fatal. And I'll talk about this a little bit later, but if they're delirious, they're not going to eat and drink, and they're going to die. And most patients, the vast majority of them, would like to prolong their life if you can do it without causing them more suffering, and they can have some kind of quality. And so this is an intervention. If we catch this and intervene, it can prolong their life in a meaningful way, hopefully. And sometimes a lot of the time they'll start off hypoactive, but then they'll become agitated. And so if we can intervene before they are actually agitated, then all the better for everyone. So my argument is it matters, and we need to pay attention and watch for it. What intervention we do and how aggressively we manage this will depend very much on the situation, but we need to be really paying attention to it. So basically, again, if there is a mental status change, someone was clear, they are no longer clear, they're more agitated, they're more confused, they're suddenly much more anxious and upset, or really seeming much more depressed, or just much more drowsy, and they're sleeping much more of the time. This needs to be on our radar screen as something that may be going on. I'm very withdrawn all of a sudden. Well, what's going on? You can use a mini mental status exam. I'm not going to get into that. But even if, again, I'd recommend not just doing a normal conversation. You need to, at least if you do orientation questions, just, hey, can you remind me where we are? What's the month and date, month and year? That will get a high percentage of them. And if you can ask some other questions, you can get in more. But that is something that's one of the reasons it's not missed. Is you just do a simple question, how you feeling, and just basically asking things that they can either tell you about how they're feeling right now, or they can fudge it and easily, and you wouldn't know the difference. And sometimes family will deny that they're confused, especially if that's more of a dementia issue, but they're more likely to notice it when it's sudden, but still.